all right, let me try change a venue, so maybe I'll post this one quicker. Um, I do the videos and I just kind of let them languish in my hard drive. Um, Sometimes as a nurse, you want to say things to the patient, or the doctor, family, or other nurses even, and you really probably shouldn't. Sorry, that's my cat. She is stealing my other cat, my daughter's cat's medicated food. It's already finished. Sorry. As a nurse, you have a lot of knowledge, and you're entrusted with a lot of things, and you need to sometimes bite that tongue and not say it. Things you shouldn't say. I mean, it's diagnosis. That's not for us to give. Treatment options. We educate, but we shouldn't suggest. You shouldn't suggest things. This treatment center is better than the other. You're not supposed to. You're not supposed to. There's ethics involved. Even if it's well-meaning, but definitely not diagnoses. I mean, if it's on their chart, fine, let them read it. I said, no, I'm not even gonna read it for you. That's not my job. That's beyond my scope. That really is beyond our scopes. Doctors get very touchy with that, and I understand that. That's what they're paid the big bucks for. She can deliver the bad news, frankly, in my opinion, and that's what she's paid the big bucks for. But there are other times, you just got to bite it off. I had done a video recently, and it was charged, and I was rushing into a room where another nurse was like, help, her patient was bleeding out from his penis. And they had just done a coup on him fully, and there was some trauma, but a lot of frank blood gushing out is not good. So she's like dabbing at it, and it's like, and I'm like, and the tech was laughing later on because he's like, "What'd you do?" I was like, "I used my kung fu grip." You have to clamp it off, honestly, I wanted urology and, just nephro and whoever. I wanted somebody to come in to help, but this is night shift. Night shift, you kind of have to just figure it out on your own. Call the hospitalist. They didn't end up coming till much later anyway, and they were like, "Oh, it's not bleeding." I said, "Yeah, because I clamped it off my hand for like freaking 10 minutes, dumbass. I'm not gonna let the guy bleed out." But what I'm getting to is I talked to the patient. I was like, "So, sir, how did this happen?" The primary nurse is running around trying to get help and trying to get whatever regals and other people to come in and not calling an RT. We don't need to call an RT for that scenario. You might think if you're bleeding penis, yeah, you want an RT. It's like, so you really shouldn't be tugging and playing with that. Older gentleman, not quite with it. Maybe, I don't know. I did have him as a patient a while back. He said, "I didn't do anything." I was like, "Well, and I said this in the other video. I was like, "Well, if your penis starts profusely bleeding like this for no reason, you're in some significant issues, sir." I want to, and that's what I said. I wanted to say, "You lying sack of crap doesn't spontaneously bleed on its own." Even if it was a coup and we jammed things out, we're not terping you. He's probably going to end up having a terp, but it's not us doing terp. It's a laxative catheter. It's not going to do that much kind of damage. It shouldn't do that kind of damage. But again, if it does, then we got bigger issues on our hands. I say, "You sure? You want to change that story of yours?" But I just suggested, I said, "Look, lead him to that conclusion. Say, look, if it really is bleeding like this, if your penis is falling off, we got some other issues going on." But you have to bite that and choose different words to get your meaning across. You know, I had a patient where, you know, she was very demanding, very whiny, alert and oriented, don't get me wrong, but very, very demanding, very demanding. People had warned me. I finally got her. They're like, oh my God, you know, and they're like, oh, you got it, you know. So I say, yeah, yeah. I handled her very well, actually. Just had her 2 days, no issues, really. But she says, okay, she's making every demands in the world. That's that meeting. She goes, I'd like to have some ice. I say, sure, no problem. You know, clear liquid diet. Sure, you can have ice. But I want it lukewarm. Did stop me for about a split second there. I said, no. And she's like, what? I was like, no, I'm sorry. You can't have lukewarm ice. And she's like, well, why? I just want it lukewarm. I was like, I'm sorry, it doesn't come like that. You know, you can have ice. I can give you lukewarm water, but lukewarm ice doesn't exist. I'm very sorry. You know, could have used different words. Could have started really getting into it with her. She's alert oriented. It's not developmentally delayed or anything, as far as I know. It was undiagnosed then. But you have to choose your words carefully. Bite it off. I was charged, you know, I had to set an example. She was my patient. I was primary. So, you know, I warned the next nurse. Yeah, she's could be very demanding, and you know, she was like, "Well." Another instance, I'll give you another one. Where this is the killing season, right? And the fresh residents are out, and they really don't know. They're coming on. I've even had this for new attendings, like they're making the transition from PGY4 to attending, and it's their show now. You know, I think I said this in another old video. I mean, I had a patient I had to call RT. He wasn't even my patient yet. I mean, literally hadn't even got the room. I had to call the RT en route in the hallway down to his room during admission. I was like, are you freaking kidding me? Had a seizure and had to call the RT. I was like, he's not my patient yet. The charge at the time was like, you think I got it? All right, so he hawks up a loogie at the end. You know, he's recovered. He's posted though, and attending new attendings there, giving, you know, orders, and she's seen my got a big loogie, and the critical care nurse, because we have them come to all the RRTs, whoever's charged of the ICU basically for the day, was there kind of helping, taking orders and cleaning up. We're doing all that, and it was primary. I was like, I mean, I literally didn't have the room set up yet, totally. Like the welcome back, I didn't know where that stuff is. We just finished the RT. And I know this guy. I have had this guy before. He's a frequent flyer. I stick out my hand, let him hawk it up into my gloved hand. I glove it up and throw it away, because otherwise it's going to end up on the sheets, right? The attending's gagging. She's turning a pale green, and she's Indian. So I was like, ooh, it's a nice combination of colors. And the CCRN is like, welcome to MedSurg. You know, she looks at me. She's like, the new attending staggers out. You know, you want to. The CCRN chose her words. I just like, you know, welcome. Could have, you know, embarrassed her some more, I guess. You know, she's been with us now for 4 or 5 years. So I work with the attending and the CCRN. They're all nice. They get along. It's all good. But you choose your words politically, you know, like, you know, the bleeding penis. I wanted to give the hospitalist an earful though, because I have a working relationship with him. Another hospitalist came along later on, and she was just like, I have a good working relationship with her too. But again, it wasn't my patient, so I didn't really get in depth with them. But you have to be politic. You have to know who you can kid around with and who you can't. It's very touchy these days with HR. Um, but also, a lot of this ends up on charts. So you have to be careful. You know, the next night, the hospitalist, I need not to, you know, that's very, you know, like Eastern Slavic European type of lady, you know, very businesslike. The other two are very, you know, it's like, yeah, yeah. Are we going to happy hour after this? You know, that kind of thing. So, give and take. And you approach them accordingly and pick your words carefully. I have to stress that. A lot of times people, you know, just think they're just words. Unfortunately, a nurse mentioned this recently. We're, again, talking about scenario, and the doctor made some whatever, you know, and she looks at me later after the fact. She's like, it's a good thing we can chart anything we hear and see. That goes on the record. I said, yeah. That, although he was a cardiac fellow, so he's not a young resident, little resident, but he should have known better. I didn't get into it too much. Not my patient again, but I was charged. It's ridiculous. Another day I was charged. You know, I was like, you know, we should have just called the code blue. You know, sustained VTAC, but you know, I mean, we were overruled by the higher ups. But you know, that's like, chart it. You heard it, chart it. I can't chart it because I'm hearing it third person. You know, I'm like that removed. I'm this guy, but you can chart it. Definitely put it on the record. You know, this guy wants to play with his license. Don't play with yours. He's not allowed to play with your license. He can play with his own. So that's how serious stuff like this is. That's how serious words are. You know, yes, there's a lighter side to it, and then there's a darker side to it. So just try to stay in the light. Good luck.